She has a very illustrious career. She has completed her fellowship in nephropathology from the University of North Carolina. She has a brilliant academic record, including silver medal at the MD, which is the highest academic medal, the Noller Award, and the gold medal in surgery and various other subjects. She is an academician par excellence, including 293 publications, including 189 in nephropathology, 11 chapters in textbooks, and she's the vice president and the ex-secretary of the ISRTP. Madam, over to you for the talk. Really looking forward to your talk. Thank you so much.
Thank you, Dr. Gayathri. And before in the meantime, I'm sharing my screen and get started with my presentation. I want to thank IIPM for giving me this opportunity to talk on a topic on vasculitis, which I really love reporting or reporting as well as picking up this vasculitis. And that's why the topic I chose is vasculitis in biopsy and surgical material. Did I miss it? And I think I might have missed earlier, but I hope I'm not missing it right now. And before I start, I would also like to thank our HOD, Professor B.D. Radotra, who kind of proposed our name, and he thought that maybe I can do some worthwhile teaching. So thank you, sir. So to begin with, let's see what happens. How do we come across these biopsies or surgical material where we can pick up vasculitis? So there are two scenarios. One is where the diagnosis there's a clinical diagnosis where we are expected to pick up vasculitis because clinical situation is such. So we have skin biopsies which are taken up for palpable purpura or non-ileal ulcers. Skin biopsies obviously for rapidly progressive renal failure. Nerve loss when clinicians are thinking of mononeuritis multiplex, or whenever there is loss of sensations. Nose biopsies we do get once in a while when the clinicians are thinking of granulomatous polyangiitis and there's no other tissue which is worth or which can be taken, and nose is involved. Sometimes lungs where non-resolving nodules are there that are also submitted for our diagnostic material, and temporal arteries for giant cell arteritis. So these are the biopsies where the vasculitis is expected, and if we don't find in first cuts, we make it a point that we do serials till the point we tend to get some inflammation or some evidence of healed inflammation. But when we pick vasculitis based on our hunch, are the scenarios where the clinicians are not expecting, like when patients come with ulcer or GI bleed or a gangrene which is operated in emergency, we get a length of bowel. So simply diagnosing them in gangrene or consistent with gangrene is not enough. That is the situation we should try to pick up these vascular injuries, because that becomes very important, which I shall talk how it matters. Sometimes when we pick up these lesions at a later stage, when there is already a stricture or obstruction, like for example in GI, so those are the situations we are going to where it will be pathologist hunch that to pick up those cause of those stricture or obstruction. So as we know, I think most of us would have seen this diagram very often. This comes from Chapel Hill, where Professor Janet and Ron Fox, their working place. And they gave this nomenclature, which has been updated in 2012. The main crux of this figure is that we can have vasculitis ranging from smaller arterioles, these capillary size vessels, medium vessels and larger vessels. So this is based upon the size of the artery, but not only the size, also we take into account the serology. That means whether ANCAs are positive or not, whether anti-GBM antibodies are present or not, and what is happening in the tissue which is given to us. If there are immune deposits in the tissue, then our diagnosis is likely to change, though all of them are small vessel vasculitis. Similarly, I'll talk of these clinical scenarios, how we differentiate these, though the level and morphological entities may be same, but our diagnosis will be different depending on the clinical scenario. So what we have to take into account the serology, the clinical setting, as well as the size of the artery which is involved. Similarly, medium-sized arthritis are polyarteritis nodosa and Kawasaki disease. But we have to remember that any small vessel vasculitis can involve large vessel as well as medium as well as larger vessel. We have seen this in our own experience in the autopsy material. So small vessel can involve larger arteries, and larger arteritis can also have an element of involvement of smaller vessel, smaller arterioles, though it may be less often. So in larger artery arteritis, we talk of Takayasu arthritis and giant cell arthritis. And also added to this whole gamut has been an IgG4 related aortitis, for which we do see in our surgical material, the surgeries done for aneurysms. So I have put these green bars because these are the situations where immunofluorescence would be required to prove these, in addition to our morphology. Even in medium vessel vasculitis, if we have to make immune mediated vasculitis in the setting of lupus or rheumatoid arthritis, for example, immunofluorescence done on artery does help to prove that it is an immune mediated injury, which sometimes helps the clinicians in taking the treatment decisions. So how do we decide which is small or medium or large artery? Intraparenchymal arteries, for example, this is section of a kidney. So intraparenchymal arteries are labeled as small vessels, which includes arteries, arterioles, capillaries, venules, and veins. Medium ones are ones which are visceral arteries, like kidneys, coronary arteries, mesenteric arteries. Those all are taken as medium vessels, and the larger arteries are these central arteries. So these are larger arteries. And as I already mentioned, there can be involvement, small involving large and large involving smaller branches is a well-known fact. Then whenever we see an arthritis, we tend to age it because it also has a diagnostic implication. If there is only fibrinoid necrosis with neutrophilic debris and leukocytoclasia is there, that is what is acute arthritis. When this is obviously after some time, this fibrin is going to get resolved, and what we are going to get is replacement of this fibrinous material by fibrosis and lymphomononuclear cells instead of neutrophil and neutrophilic debris. And this, after some days or some weeks or months, what we are going to see is the telltale evidence, which we are going to pick up. As a pathologist, we have to keep an eye on this by ordering special stains. And what are we going to find is that break in internal elastic lamina. This black line, if it is broken, indicates that there has been a past evidence of vasculitis in this particular site. Now, what happens whenever there is vasculitis? There is obviously bound to have a tissue reaction. So tissue reaction again would depend upon what is the stage of our arthritis. If there is an acute arthritis, so obviously at that stage I'm going to see necrosis. But if I see it a little later, I'm going to see sclerosis. Similarly, crescents could be an early crescent, which are cellular, or maybe fibrocellular or fibrous, depending upon at what stage the biopsy has been done. Similarly, at an acute stage, if GI biopsy is done for GI bleed, we are likely to see acute arthritis or an active arthritis. So these are the features which we are going to see depending on the clinical scenario. As I said, that small vessel vasculitis or a medium vessel vasculitis would involve medium size of a medium caliber. So we are unlikely to see injury in smaller capillaries. So that means a glomerulonephritis will not happen in polyarteritis nodosa or Kawasaki disease. Similarly, if there is small vessel vasculitis involving medium vessel, then a kidney or any organ can show infarct or scarring in the form of scar. If it is GI, you may see in the form of stenosis, or the patient may present with obstruction. So patient may present with GI bleed, obstruction, gangrene. So we have to keep our eyes open. We have to keep our spectrum of lesions, which we are going to see, very open. Only then we are not likely to miss the diagnosis. I'll show you an example of how chronic changes in a larger artery would cause a loss of parenchyma in kidney. I have an example of that. So let's start with the kidney. In kidney, at acute stage of vasculitis, we see fibrinoid necrosis, which is later replaced by a scar. And then you have different crescents of different age. Like this is a fibrous and this is a fibrocellular crescent. Now, just taking two examples, these are two adults having, mainly having respiratory symptom with having systemic symptoms, as well as there is renal dysfunction in the form of RBCs being there, and there is some albuminuria. Other lady presents with RPRF. So in first case, what I saw was there is a kidney biopsy. More than 50% are having crescent. They are of different ages. They are fibrous and fibrocellular and a cellular crescent. These crescents are having a granulomatous reaction around them, and there were independent granulomas also. So like this kind of independent granulomas are there, giant cells scattered in the interstitium, and an artery showing us this kind of granulomatous inflammation. A smaller arteriole again showing us arthritis. So on IF, it was negative. So since there were more than 50% crescents and it is negative for immunofluorescence, it is a crescentic post-immune. Now, how do I go about it further? So once we have proven that this is post-immune crescentic, now we have to look at the other symptoms. So if there are no systemic symptoms, so it will be a renal limited post-immune crescentic. But if there are presence of granulomas, but patient does not give any history of asthma, then this will be, a patient will be labeled as having a systemic vasculitis, which goes by the name of granulomatous angiitis, granulomatous inflammation with polyangiitis, or earlier known as Wegener's. In presence of granulomas, if the patient has asthma, may have eosinophilia, which is not must, then this patient is likely to be labeled as eosinophilic granulomatosis with polyangiitis, which was earlier known as Churg's disease. In absence of granulomas with the similar post-immune crescentic and absence of any of these upper respiratory tract involvement, this is likely to be labeled as microscopic polyangiitis. And we have to remember that 75% patients of the ANCA GN have systemic vasculitis. It will be only 25% of the patients which are not going to show a systemic vasculitis. So in this case, as we boil down to it being a post-immune GN, he was ANCA positive, and since there were interstitial granulomas, we labeled it as granulomatous polyangiitis with C ANCA positivity. If the same patient did not have interstitial granulomas with the same morphology with P ANCA positivity, this patient would have been labeled as microscopic polyangiitis. Does it make difference? It does, because this disease is supposed to be bad as compared to granulomatous polyangiitis. This tends to be more recurrent, doesn't respond to therapy that well as compared to granulomatous polyangiitis. So this difference is crucial. That is why to keep an eye on granulomas becomes important. Similarly, same set of patients, the pulmonary symptoms are also likely to be different. Like in granulomatous polyangiitis, we tend to have nodules, whereas in microscopic polyangiitis, what we get is these ground glass opacities, which are equivalent to pulmonary hemorrhages. We don't get any organizing inflammation here. So this is a section from one of the autopsy cases where we see this kind of a sclerosing lesion along with these hemorrhages, which on microscopy did show vasculitis, these kind of randomly arranged giant cells and inflammation and fibrosis around. So this is what we see in cases of non-resolving nodules, which turn out to be granulomatous polyangiitis. Whereas in cases of microscopic polyangiitis, what we get is simply hemorrhages, old and fresh hemorrhages as confirmed by Pearl stain. These, the red color means active hemorrhage, and there has been past hemorrhages, since these diseases are likely to be recurrent. So this is how we tend to solve our these entities. Now a word about which kind of ANCA are likely to be positive. We know that there is PR3 ANCA, MPO ANCA, or these cases could be negative for ANCA. So most often the GPA tends to be positive with PR3 ANCA, whereas MPA can have either of them, 50-50%, roughly 50-50%, and EGPA is also more likely to be positive with MPO ANCA. As you see here, a large chunk can be negative also, especially with EGPA, especially when you have a history of asthma, the eosinophilia, and a negative ANCAs, still you could make a diagnosis of EGPA, right? Then coming to organ involvement. So as you see, different kind of vasculitis have propensity to involve different organs in a different proportion. For example, GPA and MPA most often involve kidneys, whereas GPA and EGPA are more likely to involve lung and upper respiratory tract, upper nose and throat, etc. Musculoskeletal system is more often involved with microscopic polyangiitis and granulomatous polyangiitis. In addition, GI, if you see, is involved almost in 50% of all of these small vessel vasculitis. Neurological symptoms, whereas, are most often seen with EGPA and less often with GPA. So this is how we have to keep in mind the overall clinical scenario where all we are likely to expect which kind of vasculitis. And for this, we need to know this system distribution. And as you see, HSP, which is an IgA vasculitis or immune-mediated vasculitis, tends to involve skin, GI quite often, and kidneys. Cryos tends to involve kidneys as well as skin, kidneys, and musculoskeletal system. Now, another fact is that in Asian countries, we tend to have more often PR3 ANCA positivity. And this P ANCA positivity is sometimes quite non-specific also. Like it can be positive in many inflammatory diseases like tuberculosis, ulcerative colitis. So we have to keep in mind that all P ANCAs are not likely to be associated with primary vasculitis. It could be an epiphenomena, and one needs to be very careful with that. I'm just demonstrating this third case with this similar intent. This male, a 56-year-old male, had cough with RPRS, almost like a rhinopulmonary syndrome, was P ANCA positive. When we saw the biopsy, it is, as you see, there are crescents, there is arteritis here. There were these kind of suppurative granulomas, some of which were centered around these arteries also. There are these giant cells and underlying glomeruli not showing any proliferation. Granulomatous arteritis, different stages of crescents and involvement of glomeruli. So it was almost like what we call as GPA. But a lung biopsy in this case was done because clinicians had little doubt about, they were not clinically very happy with the diagnosis of GPA. So a lung biopsy was done, and as you see, there is a necrotizing granulomatous inflammation with AFP positive. So this would have been disaster if they would have just gone by GPA. The clue here was basically this large size of granuloma. Generally, we don't get to see in kidneys. Though we do see granuloma, but they generally tend to be smaller in vasculitis. So that was a hunch for not going upfront, considering it to be GPA. And this patient was saved because instead of immunosuppression, he was given ATT. Now, another case, another situation where we have this kind of crescentic GN, but if all these crescents are of same age, and we are not seeing any interstitial vessel showing arteritis, only granulomas which are one age, arteritis only restricted up to afferent. This is a scenario where an anti-GBM has to be considered, which will be confirmed by immunofluorescence of kidney or by serology. And in such cases, even lungs will show fresh hemorrhages and there could be a flea-bitten kidney. So presence of only vasculitis at the afferent is not equivalent to having an arteritis in the interstitium. Such a situation is more likely to be anti-GBM rather than being GPA. So this fourth case had crescentic GN again, had granulomas as you see here. There were lots of eosinophil present here. And when we asked for the history, it had asthma. So obviously it was EGPA. Skin biopsy was done in this case because he had some purpuric rashes. So as you see, there is fibrinoid necrosis of the arterioles. There is paniculitis, quite deep down ulcers were there. And as you see here, many eosinophils are there. But it is not compulsory, or it is not always that you are going to have eosinophils. If they are present, you can tilt your diagnosis towards being EGPA in presence of granulomatous inflammation with vasculitis, but it is not always, so that we have to keep in mind. In a chronic case, you are likely to see this kind of arthritis, which you may pick on EVG stain by this break in internal elastic lamina, and lots of eosinophils will suggest you. Then you can have immune-mediated vasculitis in two more settings. One is in IgA, or in cases of cryoglobulinemia, where even in the biopsy you may pick up this cryoglobulinic vasculitis, which will be confirmed by immunofluorescence and EM. Another tissue which we often get for vasculitis is the skin biopsy. So in that case, we just look for leukocytoclastic vasculitis, that is presence of fibrin, presence of neutrophilic debris, confirmed by these Marshall scarlet blue stain in the form of red fibrinous stans. But we cannot and we should not try to give a diagnosis of small, medium, or vessel vasculitis based on skin biopsy, because as you know, this size vessel seen in skin could be involving a medium size vessel in a different organ also. So we just label our biopsies as having arthritis to correlate with serology and other clinical features. Like for example, in this skin biopsy, there's one arthritis here confirmed by Marshall scarlet blue and EVG showing break in internal elastic lamina. On close-up look, we have a granulomatous reaction in area close to this arthritis, and AFB was negative. So in such a scenario, we could suggest that there could be a possibility of a granulomatous polyarteritis, but which we cannot dogmatically say that it is going to be this kind of GPA or PAN or small vessel vasculitis based on skin biopsy. Now here we have two cases where GI and skin involvement has happened, along with kidney involvement in one of them. So biopsies were taken from, endoscopic biopsies were taken, because earlier they thought of Crohn's disease, but then they found the patient had purpura also. And this case, he had nephritic symptoms, abdominal issues, and skin rash. So as you see, there is this kind of necrosis, small arterioles picked up these presence of vasculitis, and skin had presence of, again, arthritis was there, and on immunofluorescence it showed IgA. So obviously this was an IgA immune-mediated vasculitis. In the second case, again, we are seeing these arthritis. Acute arthritis is there in different multiple biopsies which were done. Skin also having arthritis, but in this case, IF was negative. Kidney was crescentic GN, which was post-immune, and multiple lung lesions. So this was labeled as GPA. So what I'm trying to emphasize is the clinical scenario also matters. Just based on your morphology and immunofluorescence, we cannot label it. Another setting of vasculitis is lupus vasculitis, where again immunofluorescence is going to help you. Now coming to medium vessel vasculitis, here generally the surgical material which we receive is a skin biopsy, nerve biopsy, or resections, where generally it's our hunch that we are going to pick up. So like in this case, a skin biopsy is done, and I see a big artery showing me arteritis. There is inflammation, there is fibrin present, but again, I will not say whether it's GP or PAN. I will just say there's an evidence of arteritis. This nerve biopsy was done for a mononeuritis multiplex, and as you see, there's a good, nice arteritis present with the presence of this fibrosis around these nerve bundles. There is presence of fibrin, neutrophils, as well as presence of this neutrophilic debris. But here we are seeing only one stage of arteritis. In other sections, we had areas which were looking like chronic arteritis, and there was loss of myelin. So since the different stages was seen, so one could suggest a possibility of polyarteritis rather than other kind of arteritis, but then you have to go by the clinical scenario also. Now another GI biopsy where multiple tissues were sent. Most of them were normal except for one which had this kind of acute arteritis, and after that we received a resection. So these slides I've put just to show how on resected specimen we tend to pick up arteritis. So here we are seeing that these are sections of GI where there's an ulcer. There's no lymphoid base under it to say it's a typhoid ulcer. There are no granulomas. So that means it's not a tuberculosis or granulomatous kind of pathology. And you see there is submucosal fibrosis. So at places at edges, you see there is some evidence of healing and submucosal fibrosis. So presence of submucosal fibrosis, healing ulcer, reepithelialization, and no granulomas would indicate to me that maybe it's a case of chronic ischemia is there with the superadded acute element. Some areas had this muscle deep inflammation with element of serositis. Now at the base of these healing ulcers, we did see some arteries, vein and artery, we didn't look good. On EVG, we confirmed that there is an arteritis with a venulitis and one artery being normal. So there's always a question whether this is showing arteritis because it is close to an ulcer, but then you have to look for an artery or a vein which are deeper down because they can also show some changes. But this can give you a lead that there could be a possibility of ischemic injury. So like here you are seeing there is presence of fibrinoid necrosis, there is a inflammatory arteritis as confirmed here, and some areas showing us randomly scattered giant cell. So this kind of arteritis of this caliber artery with presence of giant cells would indicate that probably this gut probably was affected by a GPA, and it was a chronic ischemia with superadded acute fibrin kind of acute insult had happened, resulting in present situation. Now, another gut was removed where again we had acute, subacute, and chronic changes. But in this case, the diagnosis turned out to be polyarteritis nodosa because different stages of arthritis were picked up on these resected specimens. So for polyarteritis nodosa, we always tend to see three phases. That is to say the fibrinoid necrosis, which is the active phase, a healing phase, and a healed phase. So when these three occur in a segmental manner and a same specimen, you can make an attempt to suggest polyarteritis. So this is one of the autopsy cases where this kind of aneurysm was seen, where we had this thrombus with the underlying arteritis being there. There's a break in internal elastic lamina indicating that there is an evidence of healing here with a superimposed thrombus and underlying glomeruli being normal. That means it's not a microscopic polyarteritis or microscope small vessel vasculitis involving medium vessel, but rather it's a medium vessel arteritis only. The mesentery did show presence of these kind of nodules. And then as you see, this coronaries had evidence of fibrinoid necrosis. Pancreas, another medium-sized vessels did show evidence of healed arteritis, and there is a healing arteritis. So this was labeled as polyarteritis nodosa. One point I want to make on this this slide is we can have arteritis, we can have thrombosis. Superimposed thrombosis is very common with all kind of arteritis, but we have to keep in mind in absence of arteritis, if you are seeing thrombosis, then our total plan or further investigations change. Like when we report arteritis, our rheumatologists are going to get into action and they will order for ANCA, APLA, and all these kind of investigations. However, if you report that this gangrene is because of thrombosis, if it is venous thrombosis, the line of investigation would be hematological, where all causes of venous thrombosis would be looked for. If they were only arterial, then they would investigate for arterial thrombosis, and both if artery and veins are involved, then they are going to investigate for APLA. So the treatment as well as the investigation, further investigations would matter on what you are trying to convey. So always try to make an attempt that we, in all cases of gangrene stenosis, we try to pick up arteritis, venulitis, presence of thrombosis, arterial or venous, and try to communicate. Quite often you may have presence of even immune complexes within these medium-sized arteries. In such cases, pan-like vasculitis in lupus can be considered. So these are from autopsy on a paraffin sections that we have done. So what I just want to make it a point that immune-mediated vasculitis can also occur and involve medium-sized arteries. Now coming to another medium vessel vasculitis, that is Kawasaki disease. So here, most of our material is autopsy material because we generally don't get to see that in biopsies. So young female, if a young female has some evidence of arterial damage with kind of ectasias being there, some rarefication of media and some edema of the media, that is the only clue we are going to have. But when we come to arteries, in absence of atherosclerosis, why should a young lady have this kind of arthritis, this kind of a luminal occlusion? So these kind of cases, when you look closely, you will find some break in internal elastic lamina. This kind of ectasias are seen, and now more and more often angiographic studies are trying to pick up these kind of angiographic ectasias in these young patients, which come with cardiac symptoms, where there could be an evidence of ischemia also. So in a young patient, having an evidence of arthritis of this kind with ectasias should make us consider Kawasaki disease. This is another, we have 3 patients like this, and these are another patient where we see arthritis in a young patient with presence of ectasia, and this was a mesenteric artery. Only this degree of edema, some break in internal elastic lamina, intimal heaping, this is all what you are going to see in Kawasaki disease, and this generally tends to be T cell mediated with a proportion of CD68 cells or macrophages being there. Now, another kid on this block of medium vessel vasculitis is DADA deficiency, or what we call is deficiency of adenosine deaminase 2. In this disease also, we are having we have observed that medium vessel arthritis is seen most often skin and nerves, GI and brain. This is a manuscript from our institute where Dr. Aman Sharma took the lead, and in these cases, what was observed was that whenever these constitutional symptoms or these 3 symptoms are involved, an enzyme deficiency is checked for, and genetic analysis done confirms the diagnosis. Skin, GI, CNS symptom, GI and renal are the most common organs involved, most often brain and skin. Coming to morphology is no different. It shows you this kind of ulcers. These are arthritis. There is presence of these kind of chronic changes which were confirmed by the EVG and mesenteric stain, lots of arthritis. So morphology is no different. Some of the GI biopsies, these arthritis were picked up, and these turned out to be DADA deficiency, ADA deficiency, and labeled as arthritis related to that. Now, another point which I want to make is a young female, as you see, it started with ulcers like this and progressed to this degree. And what we found was there were deep arthritis was present. As you see now, this kind of arthritis was not seen in initial sections. What was required was a deeper multiple sections are must, in case you do not find your report which is consistent with this degree of damage. So always go for serial sections. Now coming to larger vessel vasculitis, we have Takayasu disease and giant cell arteritis, some autopsy cases. As you see this bark-like area in the aorta. The disease tends to affect mainly the media, and starting from adventitia, which is thickened, and you see this nibbled or moth-eaten media. And when we look at these areas, we tend to see a granulomatous reaction in response to this ruptured or damaged elastic tissue. On low part, you see lots of adventitial fibrosis. Media is damaged. There is loss of elastic tissue here, and some varying degree of intimal reaction can be seen. At autopsy, which is very important here, that we do not clean up the adventitial aspect of such cases, because this is where the main pathology is likely to be there. In some cases, there may be a stenotic pathology as seen here, where complete occlusion of arteries could be seen in cases of Takayasu arthritis. So similar degree of sclerosis could result in presence of infarcts in kidney, as was seen in this case. Whereas in another case where we received a nephrectomy and it was a non-functional kidney, I was wondering why did they remove such a normal, nice-looking kidney in a 5-year-old male. On gross examination, there were hardly any sclerosed glomeruli. But on a closer examination, what we understood was there was complete loss of proximal tubules. CD10 stains proximal tubules. Obviously, the functional unit was almost lost because of this degree of occlusion, and only distal units were left. So that's why it was a non-functional kidney and had to be removed in a case of larger artery involving the osteo of kidneys. So this is how the different kind of arthritis can impact different organs. Now, I told you that there is a scenario of IgG4 aortitis. This is an autopsy case where there was a the structure here, luminal occlusion at the level of iliacs. This kind of sections were taken, and lots of information on seen on adventitial aspect, as you see here. When you try to categorize this inflammation, keep an eye on plasma cells. In Takayasu arthritis, it is going to be lymphomononuclear cells with some granulomas, mainly T cells, CD8 dominant cells. Whereas here, not many plasma cells were seen, which on special stains did turn out that there was IgG4 positive cells. And on closer examination, we could pick up this kind of a venulitis, which was seen here, lots of adventitial inflammation. So this was IgG4 aortitis, and now we are even getting samples from these kind of resections. In present times, I think nobody can go away with without having talked about COVID. So we have received many gut resections and even limbs which have been affected by ischemia. And in these cases, what we have observed is again presence of extensive damage, arthritis, and lots of venous thrombi. This has been the hallmark of these kind of limbs sent for acute ischemia in this COVID period. ANCAs, APLAs, and all have been negative. So for all this material, I definitely want to acknowledge my institute, that is PGI, where this practice of doing medical autopsies was initiated by our forefathers, and our teachers have really taught us how to pick up this arthritis, because you really need to have learned the hunch of picking up these arthritis. And obviously we are indebted to the patient and patient parties who have really lent their bodies for the autopsies and surgical material which is given by our expert clinicians and surgeons. So we are really thankful to them. And with this, I end my talk. Thank you so much.
Thank you so much for a wonderful lecture. It was very informative and with excellent images, and you've given us a roadmap, and hopefully we will also not miss these very difficult cases. Actually, I really like the fact that you kept stressing on the clinical, the serological, and you have to see the whole thing in the context, because again, there are so many mimics and there are atypical features. So vasculitis is truly a multidisciplinary approach, and you need to have clinical history in detail with the serology. Only then can we make. Thank you so much. It was an excellent talk. Any questions? I don't see any questions in the chat box. The panelists are most welcome. I welcome them with their comments, and thank you so much once again for a wonderful talk.
Dr. Gayathri.
Can I start with a question? Yeah, sure. Anyone wants to go ahead? Yeah.
Thank you, Dr. Ritambhara, and also Dr. Gayathri for a very nice presentation of this this thing. And I was thinking about the arthritis, that I am an asthmatic patient, so there might be some changes in my lungs also. So anyway, very nice presentation with the pictures. So I am very much thankful to you.
Anyway, so this was hello. Okay, so this was an excellent deliberation on different types of vasculitis and a wonderful demonstration of cases. I would like to thank Dr. Ritambhara for teaching us the small diagnostic tips and nuances and subtle differences in the different types of vasculitis favoring this one or that one, and also teaching us as to how to synthesize the information once you slide on the microscope. So I think I would like to place my appreciation for a wonderful colleague. I have just a small question, that because I am not a man who has seen IgG4 related diseases, maybe CNS I know, but how many cases we have about IgG4 related aortitis? So how frequent it is, yeah, or how many cases you have seen, or what is our experience? Because about aortitis, I don't have much knowledge.
So one case was this autopsy which I demonstrated. After that, Dr. Ajay Selvania has sent two aneurysms which he dissected. In those cases, we suspected. Then we kind of discussed and asked them to do IgG4 levels which were high, so that PET was done. Then they picked up something in pancreas, and so whole story got unfolded. Though he initially presented with some, it was mainly a mediastinal issue, for which they picked up a aneurysm and when operated, and that's how like chain of events happen. We discussed, we ordered further investigation, and finally it was proven to be IgG4 related arthritis in both.
Very good.
And one of them was subclavian aneurysm, which was very odd. So they were kind of in a dilemma whether to believe us or not. But once we said we have seen it, so then they went ahead with investigation and were kind of happy to have the diagnosis.
Because I have seen a lot many Takayasu
Yes.
arthritis, and of course the temporal arteritis, but IgG4 related. And very nice, you have pointed out the difference between the type of infiltrate, etc. Rest may mimic, I mean, adventitial inflammation, etc. So Takayasu, we had a good series, even with brain involvement also. And you know, we both of us know that we
Capillaries, pulmonary arthritis.
pulmonary arteritis and all. We didn't publish it, but we had been noting all these because we had CPCs and also that is it. And Kawasaki, I must say that we have a lot of material, and we have plenty of cases also, much more on clinical side than what
Yes.
we get on autopsy. But I think in vasculitis, it is something that you have to suspect. Once you suspect and you have that eye on it, you are likely to not miss it. Rather than pick up, I would say you are likely not to miss it.
Yes.
So that's how I think the things go. And anyway,
Like GI resections and stenosis,
yes,
that's one area like if we pay heat, we do come up with that. But
yes,
most often we say consistent with
gangrene, yes.
consistent with gangrene. That is not. You don't have to leave it there. You have to give a cause. And
And
if we take an attempt, we do find
and
out.
you know this, you have to very quick also. You have to very quick. I got one GI resection and there was gangrene, consistent gangrene. But when I looked at it, it is long back, about 20 years back. So I found that, you know, what is the reason for this gangrene? So I found, I went back to the specimen. I found there were nodular lesions, in fact, in the mesenteric arteries. So I immediately phoned Dr. J.D. Wig that time, that, sir, you have a case which is gangrene, but the cause is Polyarteritis nodosa. He said, I can't do much. The patient has expired. So by that time, actually, he was very indifferent. I was wondering that I had come recently from England, so I was very polite and nice to talk and telling him that this is immediately I'm complaining to, but he was very indifferent. So I thought, what is happening? But anyway, the patient had expired. So you have to be very quick and yes.
Generally, what I do multi-prong approach. Like I inform the surgeon, but I know he's not going to pay heat. So I call up our rheumatology team. Okay, please go and see that patient, because I'm pretty sure surgeon is not going to bother about it, because surgeons are surgeons, I would say. So you have to push rheumatology team. Okay, EM OPD when this patient is there, please send your somebody to go and have, and then things get channelized, and many patients get saved, which is what I like about that fact, that if you talk to your clinician, push them to have a look at the patient, you can help saving some patients, because otherwise they'll come back with a perforation again, and at one time we lose them.
Thank you, Dr. Ritambhara. Can
Yes.
It's really a nice talk, and I learned a lot. There is no question, but I have a very basic question. At least you can explain to because most of the MD people there, how one really distinguishes primary vasculitis from a secondary vasculitis? Because we have seen even in mucormycosis, I have shown bilateral renal mucormycosis, you have vasculitis. So how really the younger people really can think of that, how to distinguish between these two entities?
So there is, I think, if on morphology you can find some clue in the tissue there around it, if you find some organism, if you find some, if your anchors are double, you are dual positive anchors, that indicates drug-induced anchor pathology. So we have to take clues from everywhere, whether your anchor, which kind of anchor is positive, whether patient has any systemic inflammation. Like if patient is more like tuberculosis and P anchor is positive, I would stop and I would not push my P anchor as being primary arthritis, especially being in India. First, we would like to kind of take out the conditions where some cause could be behind it, because those causes, if treated, the vasculitis is obviously secondary to that. After having excluded them on morphology and serology and clinical scenario, only then we should come to the point of it being primary vasculitis, because first dictum of diagnosing primary vasculitis is that we are assuming that we have made all our efforts to exclude any secondary cause, whether in the tissue, whether in the history, or whether in the investigations, serology or radiology, or whatever is available to us. So that is very important.
So many times in the lung, I think we have also faced a similar problem, whether it is inflammation-related vasculitis or it's really a vasculitis caused by a vaginous or a GPA. So that is the issue I think many people are facing. Many people are faced, in fact. I don't know, but it's a really a difficult area, but one has to think what you have said, that one has to really think about a multidisciplinary approach and other things.
Yes, I think very valid point, and Professor Das has raised a very important question. Ritambhara, you remember that in one of the Wednesday CPC, we were going to present, it was your presentation, and we were going to present as vaginous.
Yeah.
I told you that before we present vaginous, can you do ZN stain? Because we found some necrosis, very little difference, and we did ZN stain, and it was found to be positive. So the entire diagnosis changed.
The last moment change, and the oddity in that case, why we were really worried, was that crescents and necrosis was seen only in one kidney.
Yes.
A systemic disease has to be bilateral. So, and the percentage of crescents were just 5% or something like that in the whole kidney. So that made us suspect something is wrong. And that in that case, pancreas was the main site, which is again relatively odd for a GPA. So last moment, like Tuesday, we are preparing. I have to make my write up, and I think 2:30 I get this ZN, and we sit across double header, and it was positive.
So actually, for the vasculitis, I think it is very important to exclude the tuberculosis and fungal infections. These are the two which need to be excluded before any patient is labeled, as far as India is concerned, before any patient. I think Ritambhara has already elaborated too much on it, so I don't need to go into it. But the basic fact is that you have to exclude secondary vasculitis before you really finalize that this is a primary vasculitis.
So even in COVID, sinonasal mucor, in one of the case, I was just discussing with one of my colleagues that if I had not seen the second section which had mucor, it was just like GPA. There were suppurative granulomas, there was arthritis, like it was just like a GPA. if I didn't have the second or third section which had mucor, it would have gone as mucormycosis based on that particular section. So ruling out primary causes becomes very important. Like we should make all the effort before we really label somebody as primary vasculitis.
What about the experience from the other people? I think they are silent probably.
No, Ritambhara,
Yes,
I
sir.
think it's a good presentation. I've heard more of Ritambhara because of her interest in liver. How she often accompanies her husband actually, and so we have seen her more. But it was a wonderful presentation. Ritambhara, I think one thing is that in many of the primary vasculitis, except of course some, one is renal involvement is very important. You hardly get renal involvement in most of the secondary ones that you have seen. And of course, you have mentioned about tuberculosis affecting one kidney and not the other. So that's one thing, I guess. And even the cutaneous lesions. But of course, you will always get lesions which look so much primary, but they are secondary.
Right.
Ridhamra, one question I want to ask. Earlier, that so-called aortoarteritis, which was very common in our country, many of them related to tuberculosis, many were giant cell and all that. I think now the incidence may have come down. I don't know in Bombay, Dr. Gayathri can also tell whether you get such cases. Earlier there were quite a few, and now it has come down. And how many of them do you know, at least theoretically, are actually IgG4? Because at that time people didn't know about IgG4. It was never there. It was all associated with tuberculosis, many cases, many things were because of giant cell or something like that, giant cell arteritis. So if you can just throw light if it is there.
So, like with the knowledge which we know, like IgG4 can be positive. I can recall a patient recently came from Nepal. She was mother of a doctor. She had some symptoms which were suggesting towards aortoarteritis. This PET scan was done, which really highlighted the outer aspect of the whole aorta. So obviously they boiled down to aortoarteritis, and then one skin biopsy was there which had lots of inflammation, arthritis, but many plasma cells. So at that point of time we did IgG4. Maybe earlier we wouldn't have done it, and we would have labeled it only as a Takayasu arthritis. But maybe nowadays whenever you have this now I think radiology, PET scan, these all are picking up these aortoarteritis more often, and they less often reach pathologist table, I would say. But now I think they do get these IgG4 levels done to rule out IgG4 related arthritis, because probably there is some difference in their treatment also.
Hmm.
So
Yeah,
can I make one point?
yeah, sure.
So you talked about renal involvement. From experience from our autopsy material, what we have learned is if you have renal, spleen, and lung involvement, then most likely that is likely to be primary arteritis. That has been experienced over the years. This 3 organ involvement is kind of goes together.
Yeah, I just wanted to answer. I wanted to agree with you. What you said is that most of these aortoarteritis are getting diagnosed radiologically, so they are not really coming to the pathologist. But we do a lot of autopsies. Like we have been doing medical autopsies, a large number in Mumbai. So we do still get a large number of aortoarteritis, non-specific aortoarteritis cases, the usual ones, or some of them in typical forms. And it would be good, like actually, if we could pull them out and study whether they are, IgG4 related, so we could look that up. But we do get a substantial number.
Yeah, you're right. Clinicians do see. See, many of these diseases now are being diagnosed by non-invasive means, or I mean, by imaging and other things. which is actually the gross pathology of today. So it's true, but the clinicians do see. But of course, they will not be able to tell whether it's IgG4 or this or that unless the serum levels of IgG4 are raised or something. And of course, the nephrologists always, as Dr. Ritambhara will know, they see a lot of these variety of vasculitis because of the
Like
renal involvement.
I think morphologically these two are, I think histologically one can distinguish if we get any material.
yeah, yes, sir.
And
Yes.
one will be dominant by the plasma cells, and then you
Yes.
do IgG4. Another one is a lymphocytic infiltrate, as Ritambhara has already highlighted. It involves initially vasa vasorum. So if we see that vasa vasorum involvement by a lymphocytic infiltrate, that will be more like a non-specific aorta arteritis. There may be some out of the histological finding, but this is I think Gayathri or other people can talk also how to distinguish these two.
No, Ashwin, histologically it's possible, but what I'm saying is earlier people didn't know about IgG4. So plasma cells, lymphocytes, nobody even counted, because of course for IgG4 there are criteria that you must have so many plasma cells per hypa field in different regions. Maybe for pancreas is different, for the other sites is different, for the vessels it will be different. Lack of eosinophil, more of this concentric or what is that fibrosis and so on and so forth. So I guess it will be good if they can pull out and see if some of these
I
cases.
think the overall clinical scenario would, and the radiology PET scan would really help. Like
Yeah, they have.
IgG4, if it is there, we are likely to have salivary gland, pancreas, and these more common organs. If they light up, then obviously we can tilt our diagnosis towards IgG4 and get serology done.
See, as far as the association of tuberculosis and aortoarthritis is concerned, I think in earlier days, Dr. Suman Kinare had done this work, even in experiment.
Yes.
But as far as PJ is concerned, we didn't. This was I think incidental. Probably we never found any really cause and effect relationship. In fact, the CPCs that I have done, we on the arch of aorta are over the larger arteries, nice caseous lymph nodes were sitting, but they were just sitting there. They did not evoke any inflammatory response in the. Even Dr. Sumar Kinare's work, when they injected tuberculin and tuberculous antigen in the rabbits and all, giant cells, I mean, they had some evidence, but I don't think really there is a cause and effect relationship, and association of tuberculosis with aortoarthritis is not well proven. So I think the initiating agent may be something else, and the cases that we get at autopsy, they are terminal cases, burnt out cases. So we do see all those elastic tissue changes which Dr. Ritambhara has shown and so on. We have got only few cases which are very early, where fibrinoid necrosis, and so we have their entire spectrum of any arthritis has been seen. So therefore, what triggers it? Tuberculosis may not be. At least currently, we believe that it is not tuberculosis which is causing. We have so many cases of tuberculosis, but aortic sections, they do not show any adventitial inflammation or those vasa vasorum inflamed, and any changes in the media elastica and so on.
No, you're right. Since late 70s and 80s, no, the
Yes.
tuberculosis story gradually came down.
Yes.
And it's true, tuberculosis doesn't affect disease.
So like
But
data deficiency arteritis, now earlier probably they were being labeled as PAN. Now
yes,
they do enzyme assay and they do genetics, and those patients now we are giving anti-TNF therapy. So and we are salvaging them. Maybe earlier they were not non-responders of PAN. They were. So I think as we learn, as we evolve, our terminologies will keep changing, and same entities might get labeled differently, and things might improve for patients. They are improving, I think.
Do they
finally,
produce aneurysm?
Uh,
Dada data deficiency,
So they can.
they
Yes.
produce aneurysm. This
Yes.
small aneurysm, which
Yes,
is
sir.
used to see in polyarteritis nodosa.
Yes, sir. Yeah, the case I showed had typical of that.
Dr. Ritambhara, did you see any case of very severe limb ischemia and COVID?
Yes, sir. We
I
had
mean, they had to amputate or something? Was
two,
it so
one nursing sister from Delhi, bilateral limb ischemia in 23 years old female, both below knee amputations were done.
In fact, last year, May, June,
Very
there was
unfortunate.
a sudden search of limb specimens, amputation specimen, in a so-called in a COVID patient. So I think this is a real scenario. This
So
can happen.
we have Dr. Ajay is the vascular surgeon here. He on his record 11 cases he had operated like that in this COVID period.
And the basic pathology there, I have seen some of these removed gangrene out of my interest, and I had to take a lecture, so I went through them. They show extensive thrombosis, both in arteries and veins, both small size as well as larger size. So popliteal vessels, one of the Ritambhara's cases, I think she had reported it. So I happened to go through the slides. And there is extensive long segment thrombosis, not only in the arteries, but also in the veins and the branches.
Yes.
And the neuromuscular bundles, it is extending into the nerves with giant cell reaction as well. The arthritis here is secondary to the necrosis and all. So it is not primarily an arthritis. Of course, endotheliitis is known in COVID, but basic problem was, and more important is that one of the arteries, popliteal arteries, was showing organized thrombi. It is not that it was very acute or very, it was showing almost complete occlusion at one point with the fibroblastic proliferation and so on.
Like different ages were there.
Yes.
Yeah. With
very interesting, because autopsy studies, of course not in our country, starting with those from Italy, have shown that pulmonary thrombosis and other things, because arterial vessels, that's why the entire treatment protocol changed to giving these anticoagulants and other things in severe COVID. But this limb thing is very interesting, because I think you should
In fact,
because there are so many cases of COVID all around, and if limb thing was common, this should have been in the lay press actually, because everything in COVID has now come before in the journal, it will be there in the television. So I think that this is very interesting, and as Dr. Radotra said, and you showed, it's mainly venous thrombosis rather than arterial. So it's more a venulitis thing.
So
And
in both arteries as well as in the veins, and the gut resection which we have in our department again shows the same. You have
almost like, and what you said is almost like thromboangiitis, which
in fact last year I happened to talk to one of my friends in US when we were struggling to start autopsies, etc., and I happened to talk to him about the presentation. Their presentation in his hospital, he's in a private practice. Their hospitals, they were getting stroke patients and gangrene gut. So we didn't have those days. It was last year, mid-year, when we had in May.
that's true.
So they had more of stroke and intestinal ischemia. So pain, abdomen, and could be ascribed to it. And I was a bit surprised. We are getting different spectrum, but now this year, in the second wave, or maybe in the May, June, we had a lot of cases coming as gangrene gut and perforations in our department. A lot of perforations. So
Here we saw a lot of strokes, and this one I'll have to check about the gangrene limb. I don't know whether it was that much. Anyway, I'm not.
Anyway, good.
Very good, but interesting.
Yeah. Thanks for teaching us.
So all I've learned from you people, it's nothing mine. I'm just a presenter, I would say. It's all like
it's
you.
Ritambhara.
Reversal of role.
Yes, I'd like to thank for very nice presentation, Ritambhara, and making it, presenting it so well. So everything was clear. So we had very good discussion. The discussion may go on long, but we have limited time. So any comment from Dr. Pradeep? Also seeing vasculitis, cardiac pathology.
Pradeep should say something.
Yes.
Yes.
So do you want to say anything, Pradeep? Is Pradeep there? I think he is logged in, but probably he is not able to listen. And yes, things are changing, and we have to see that many things which we diagnose in every aspect, in every tissue which we diagnose, because now the IgG4 has come. And so retrospective analysis of many tissues, not only vasculitis, we may find changes because initially only plasma cells, inflammatory, immunological, immune mediated, we never thought of IgG4 or any specific. Now we are getting more and more specific things to work out. And such studies may further help us to elucidate whether we had missed some things earlier which were there. But now they are here with other features and new features, and we have to identify them. So we have to change with the new scenario, with the new facts which are coming, and more newer pathology which we have to learn day by day with the new things. So any other comment, Dr. Mohanty, Dr. Lanjeva, senior pathologists are there, or should we end? This was our last meeting. I would like to thank all the panelists for sparing their time for last, I can say 4 or 5 months. We had very nice presentations with good participation from all the seniors, members of EC, and we had good speakers and moderators. I would like to thank all of them for sparing their time. And yes, our today's last lecture was also good in the same line. So I think, Asranti, should we end it here?
And in the end, I want to thank Vatsala ma'am also for being in all the 21 systems, for giving us so much valuable time and being there presently. Thank you so much, madam, and thanks all to the participants and EC members.
We will discuss and try to work out if we can continue further, not 4, but at least
possible, I'll continue, madam. Yes.
Yes.
And yes, madam. Thanks to Dr. Ritambhara for the excellent lecture.
Yeah, I think we have to thank both Dr. Vatsala Mishra and Dr. Asranti.
Thank you, sir. Thank
Who are
you.
thanking everybody else.
I only
Everyone, thank you, sir.
continue.
Actually, I have suggested it. I suggested it in the pitching.
Yes.
You should continue with this.
Okay, sir. I'll try.
Okay.
It is a very good program, really.
Very good program.
And secretary kept us all along in the year.
Yeah.
No, we will not be
Thank you very much.
silent for a whole year. We must do something, and we will continue with academic
Especially in lockdown time and corona time, you are-
Very nice, very nice.
Very nice.
Right.
Thank you all. Good night. Namaste.
Thank you, President Secretary. Thank you.
Good night.
Namaste.
All.
Namaste.
Thank you.
Nice lecture, nice illustration. Every